Imagine trying to take a deep breath, and something is stopping you. Not your lungs, not your airways, something around your lungs. That something is called a pleural effusion. It's fluid, more than there should be, sitting in the thin space between your lung and your chest wall. Normally, that space is nearly empty. When fluid builds up there, it pushes against the lung from the outside. That's what makes it hard to take a full breath. That's what creates that pressure in your chest. And that's exactly what a thoracentesis is designed to fix. Thoracentesis is a procedure that drains that extra fluid. A trained doctor uses a very thin needle, guided by ultrasound, to enter the fluid space through the chest wall, draw the fluid out, and let the lung expand again. To help you understand what's going to happen to your body, we're going to use the RadVeritas framework. What enters, what leaves, what stays. Because when it's over, only one of those things is different from right now. Let's start with what enters your body. First, the ultrasound probe. This goes on the outside of your back or side, gently pressed against your skin. It uses sound waves, not radiation, to create a live picture of the fluid pocket inside. Second, local anesthetic. Before anything else enters, the doctor injects numbing medicine into the skin and the layers beneath it, right down to the lining of the chest wall. You'll feel a brief sting, then that area goes numb. Third, the needle, and sometimes a small, flexible tube called a catheter. Once the area is numb, this thin instrument is guided through the chest wall into the fluid. The ultrasound is watching the whole time. The doctor is aiming for the fluid, not the lung. The needle goes around the lung. It goes between the ribs. It goes into the fluid. That's what enters. Here's something worth knowing about ultrasound guidance, because it matters for your safety. Before the needle enters your body, the doctor maps out the exact location of the fluid. Fluid shows up clearly on ultrasound. It appears as a dark space, easy to see, easy to measure. The doctor marks the best spot on your skin, the place where the fluid is deepest, closest to the surface, and farthest from the lung tissue. Then, during the procedure, ultrasound confirms the needle is in the right place. This guidance is a key part of what makes modern thoracentesis safe. It replaces guesswork with a live map. You'll be sitting up for this, leaning slightly forward onto a pillow or a table. That position isn't arbitrary. Gravity pulls the fluid down to the base of the chest, making it easier to access safely. Now, what leaves? Once the needle is in place, the fluid starts to drain. It flows out through the needle or catheter into a collection system, bags or bottles that the team is monitoring. As the fluid leaves, something changes inside your chest. The lung has more room. It can open up, gradually, gently, filling the space that was crowded before. Many patients notice that their breathing begins to feel easier. Not always immediately. Sometimes it takes a little time after the procedure. But for a lot of people, that sense of relief, the ability to take a deeper breath, is one of the first things they notice. The team monitors your breathing and comfort throughout. They manage the pace and the amount. You are not alone in that room. That's the question almost everyone asks. Here's an honest answer. The local anesthetic numbs the area before the needle enters. The skin, the tissue, the chest wall lining, it's all numbed. So the dominant sensation during the procedure is usually pressure, not sharp pain. You may feel a brief sting when the numbing medicine goes in, a sense of pressure or fullness as the needle enters the pleural space, possibly a strange sensation as the fluid drains. Some people describe it as a release or an odd, hollow feeling. If you feel sudden, sharp pain, tell the team immediately. That's important information. Now, staying still. The team will ask you to stay as still as you can during the procedure. They'll let you know before they move or make any changes. The main thing they'll ask is, please don't cough or take a sudden deep breath during the needle insertion. If you feel a cough coming, let the team know. They'll pause and wait. You don't have to be perfect. You just have to try. The team has done this many times. They know how to work with you. Here is the part that surprises a lot of people. When the procedure is over, the needle comes out. The catheter, if one was used, comes out. Nothing is left inside you. No device, no drain, no stitch. Just a small adhesive bandage on the surface of your skin. That's it. No hardware, no implant, nothing foreign in your body. Just the space where fluid used to be, and your lung re-expanding into it. What enters, what leaves, what stays? Nothing stays. There is a question that comes up often, and it deserves a direct, calm answer. Could this procedure pop my lung? What people are describing is called a pneumothorax, when air gets into the pleural space. It's a real possibility with any procedure that enters the chest, and it's fair to ask about it. Here's what you should know. Ultrasound guidance significantly reduces the risk of pneumothorax compared to older methods. The doctor is watching where the needle goes, in real time. Even so, the team monitors you after the procedure specifically for this reason. A chest X-ray is commonly taken afterward, not because something went wrong, but because that's how the team confirms that your lung has re-expanded and everything looks as expected. It's a routine check, not a sign of a problem. If a pneumothorax does occur, the team is prepared for it. In many cases, a small one resolves on its own. Larger ones can be treated. You are being watched. That's the point of the post-procedure monitoring. After the procedure, most patients rest briefly while the team monitors breathing and comfort. For many people, thoracentesis is done as an outpatient procedure, meaning you go home the same day, once the team is satisfied that everything looks right. Your team will give you specific instructions for activity, when to shower, and what to watch for. One thing worth knowing, pleural effusion can come back. This depends on what caused it in the first place. If the underlying cause is something that's being treated, the fluid may not return. If the cause is ongoing, the fluid may accumulate again over time. This is not a failure of the procedure. It's a feature of the underlying condition. Your team will discuss the findings from the fluid sample, if one was sent for analysis, and what the next steps look like for you. Before you leave, make sure you know exactly who to call and when. Call your team right away if you notice worsening shortness of breath after you get home, new chest pain or pain that gets worse, fever or chills, the bandage site is leaking, swollen, or looks infected, you feel faint or unwell in a way that worries you. These may or may not be serious, but they are signals the team needs to know about. Do not wait. Let's bring it back to where we started. You had fluid pressing on your lung, something that didn't belong there, making every breath smaller than it should be. What enters? An ultrasound probe on your skin. Local anesthetic that numbs the path. A thin needle, guided precisely by sound waves, into the fluid space, not the lung. What leaves? The fluid, the pressure, the thing that was crowding your lung, and the needle when it's done. What stays? A bandage, and the ability to breathe a little more freely. That's thoracentesis. If you have questions about your procedure, write them down and bring them to your pre-procedure appointment. Your team wants to hear them. And if you found this helpful, subscribe to RadVeritas for more clear, calm explanations of imaging and interventional procedures.